Okay. So this is the revision for urinary and respiratory module. Okay. Next week you are going to have exams. Okay. So you know that from biochem there were only 3 lectures in this module, and 3 lectures were taken by 3 lecturers. So I also took one. The title of my lecture was Biochemical Assessment of Renal Functions. Okay. So I discussed the many things. Now the renal clearance test. You know, the renal clearance test is one of the very important tests to see the function, especially the the glomerular function of the kidneys. Okay. So the renal clearance test, like the creatinine clearance, the inulin clearance, serum creatinine, PAH clearance or urea clearance, EGFR, cystatin C, fractional excretion of sodium. These are the different types of renal clearance test. Okay. So you need to know that if you say that there is a gold standard method for measuring the GFR in research setting. So for research purposes, usually we don't do anything that is endogenous. We do we use something the exogenous. So inulin is the one. It is a type of the polysaccharide carbohydrate. We use it. It is completely the it is completely excreted. It is not metabolized and not completely excreted. That's why we use this one. So for gold standard method for measuring the GFR in research setting, the answer is inulin clearance. Then the other clearance, we use an endogenous substance, and that endogenous substance is used to estimate the GFR, but it gives slightly overestimate the true GFR. So that is the creatinine clearance. So that it can give a bit or it can overestimate the true GFR. That means whatever the true GFR, you can get a bit slightly the what is it, a bit the over ambitious or something type of results. So remember, when you know that it is an endogenous substance to estimate GFR, and that overestimates the true GFR, that is the creatinine clearance. But if it is underestimates the GFR, that will be the urea clearance. Then also sometimes we give the the results results of the test, and based on the results of the test, you will have to say that okay, what sort of the kidney problem the patient is having. Like if a scenario is like this, so an individual is having diabetes for 20 years. So his investigation on ultrasound, you found the kidneys are shrunken, and there is persistent increase of creatinine, the serum creatinine, persistence increase. So that means always creatinine level is high and the kidney has been shrunken. A diabetic patient, so you can say that this is a chronic kidney disease. Okay, so the patient has developed a chronic kidney disease. Then another scenario could be a patient might have the hypertension, and you do the urine test. You can get the urine the hematuria, that means the blood. You can also find the RBC cast, and there will be the moderate proteinuria. Some amount of protein are also in the urine. So the hematuria, proteinuria, and RBC cast, and the patient history is patient is having hypertension. So this type of patient is, you can say that this could be a acute glomerulonephritis. Okay. Then you see that that we have talked about the glomerular filtration, then the tubular reabsorption. So the different parts of the tubule, proximal convoluted tubule, spatially proximal convoluted tubule, loop of Henle, and the distal convoluted tubule. What happens? What are the substances that are reabsorbed, and what are the substances that are secreted? And what are the substances that are completely reabsorbed? They are filtered, but completely reabsorbed. Completely reabsorbed, like glucose, the amino acids, they are completely reabsorbed from the proximal convoluted tubule in a healthy individual. Okay. Then the sometimes you see in the clinically in the hospital, the to diagnose a patient's the what is that called with kidney disease, the chronic kidney disease or something. So to estimate the GFR, the eGFR, the best single test to estimate GFR in routine clinical practice. So what is test? What that test? So it is not creatinine clearance, not the serum creatinine, serum urea, or serum electrolyte. It is the eGFR. So to estimate the GFR, so the best single test to estimate GFR in routine clinical practice, it is the eGFR using serum creatinine and equation. You know the eGFR, for eGFR, there are equations are used like the Cockcroft-Gault equation or formula and the DMRD formula. Okay, and there are others also. The most commonly used is the Cockcroft-Gault formula or equations. So the best single test to estimate GFR in routine clinical practice is eGFR using serum creatinine and equations. So you need to remember those things. Then you see if someone is having the kidney disease, so we usually estimate the serum creatinine and we do the eGFR. Okay, so the question is in acute glomerulonephritis, why there is high serum creatinine? So if a patient is having the acute glomerulonephritis, the patient's serum creatinine level gets high. The question is why it is high. So it happens is when there is an acute glomerulonephritis, so there will be reduced GFR. The filtration rate will be reduced. So that will cause the decreased creatinine filtration. So the creatinine will not be filtered properly. So there will be an accumulation of creatinine in the blood. So the leading to the increased creatinine level, serum creatinine level. So meaning that acute glomerulonephritis, reduced GFR, decreased filtration of creatinine, so that leads to the accumulation of creatinine in the blood. Then what is the eGFR value at which the chronic kidney disease is diagnosed? So you can see that in my lecture note it has been mentioned that when you can say that someone is having this chronic kidney disease, based on the what value of GFR. If the GFR value is less than 60 milliliter per minute, okay, for 3 months, okay, for more than 3 months, 3 months or more than 3 months, the patient is having the less than 60 ml per minute per square meter of body surface area, per 1.73 square meter of body surface area. So just remember it is if it is below 60 ml per minute, so then we can call it the patient is having the chronic kidney disease. If above 60, so still it is okay. Its patient is not the chronic kidney disease, but the function is getting reduced. So the serum creatinine is used to assess the renal function. Why there is serum creatinine is used to assess the renal function? So answer is if there are few reasons, okay, you may be asked to tell the few reasons. Number one is the serum creatinine is constantly produced in our body, okay, and it is freely filtered by the glomerulus. So the number one, constantly produced in the body. Number two, the freely filtered by in the glomerulus, and it is not reabsorbed. So the creatinine is not reabsorbed. So once it is the filtered, it will be excreted. Then it is slightly secreted by the tubules and inversely related to the GFR. That means the GFR is reduced, creatinine level is high. Okay, so you need to remember like this. Whoever joins, you just take them. Okay. So Remember the why serum creatinine level is raised in acute glomerulonephritis, or what is the value, the GEGFR value, what is that value that can tells you that the patient is having chronic kidney disease. Okay, and then what are the reasons why serum creatinine is used to assess the renal function? So you may be asked to mention the 4-5 reasons. So the reasons are that it is constantly produced in the body and it is freely filtered by the glomerulus, it is not reabsorbed, and it is inversely related to GFR and slightly secreted by the tubules. Then you need to know the maybe the certain you are given the patients the investigation results, and based on the investigation results, so you may be asked to calculate the creatinine clearance of the patient by using the formula. What formula? The commonly we use the Cockcroft-Gault formula, and this formula is used usually in the hospital. So you have to remember the Cockcroft-Gault formula. So if the patient is female, you remember the formula is 140 minus age of the patient, 140 minus age of the patient times weight in kg. If the female, the weight, you multiply the weight with 0.85. If the patient is male, you don't need to multiply with 0.85. Then divided by 72 times plasma creatinine value. So if you may be given the age of the patient, the weight of the patient, and the plasma creatinine value. So based on that, you will have to calculate the creatinine clearance. So it's better. I'm not very sure whether it appeared in the exam, but it is better you can bring your calculator if you need. Okay, so you remember the formula. Then what are the limitations of the EGFR? You can calculate or measure the EGFR, but EGFR might have some limitations. Limitation is not always the limitation. Limitation is if you do the EGFR in a normal patient. So the normal patient, so the patient with normal GFR. So someone does not have any kidney disease, so it will not give you any clue. If someone is having the muscle wasting disease, or someone is amputees, does not have one leg or two leg or one arm or both arms, and the high if someone consumes a lot of protein, okay, a lot of meat, okay. So these are the limitations. So the number one, patient with normal GFR, muscle wasting disease, the patient, the amputees, and the high consumption of meat. And the relationship of the serum creatinine and the GFR is inverse relationship. Okay, you remember it. Then also again, if you may be given a lab results and a list of lab results like the electrolyte results, then the serum urea, creatinine, and the plasma glucose level, all are given. So based on that, you may be asked how to calculate the anion gap. So the anion gap calculation is how to define the anion gap. It is the gap gap between the measured cations and the measured anions. So measured cations are sodium and potassium, and measured anions are chloride and bicarbonate. So sometimes you write the formula correctly, there are some students, but they calculate this plus minus summation or deduction, they make the mistakes. So even then it is like a standard 1 or standard 2 like things. So they make the mistake and they get the 0. So you have to be very careful in calculating also summation and deduction. Okay, and then you may have to maybe ask to, if it is a question, so in what are the conditions where the anion gap can be increased? Like if someone with diabetic complication like diabetic ketoacidosis, someone is having the septicemia or sepsis, some patient is in shock or the renal failure. So these are usually the diabetic ketoacidosis, sepsis, shock, renal failure. So these are the situations where you can get the high anion gap. And then also you may be asked, you see the plasma osmolality is one of the very important things. So you may require you may be asked to calculate the plasma osmolality. Okay, to calculate the plasma osmolality, usually you have to see what are the results are given. So the if you have the sodium results, potassium results, urea and glucose, then you take your formula will be 2 times sodium plus 2 times potassium plus urea plus glucose. So you do the calculation, and you must write the unit of the osmolality, that is the milliosmol per kg. If you don't write the unit, you won't get the marks. Okay, you must write the unit, the milliosmol per kg. Okay. But if you don't have in the result, you don't have the urea or the glucose value, so you just take the 2 times sodium plus 2 times potassium. If you don't have even the potassium, only you have the results, the sodium results, then you take it 2 times of sodium. That will give you also an approximate the plasma osmolarity level. Then also you had a practical like the dipstick test. So in the dipsticks, you can do the lot of tests. Okay, some biochemical test and some the presence of some other substance. Okay, so you need to you have to be uh, carefully look at the interpretation of the results. You may be asked. Okay, so what are the abnormal constituents observed in the strip? So the strip results, the results will be given. Then you'll have to say that what abnormal constituents you can see or you can observe in the strip based on the change of the color. Okay, so you have to be you have to know that one. And also you need to know what is the renal threshold for glucose. If the glucose is present, you think that in urine there is presence of glucose. So question is, what is the renal threshold for glucose? Usually it is 10 millimole per liter or 180 milligram per deciliter. Then how the ketone bodies appear in the urine? The answer is usually when cells cannot utilize glucose deprived of primary energy source. So in diabetic patients, the patient cannot utilize glucose. So the body breaks down fat into free fatty acid. So the lot of fatty acid oxidation, and then it goes to ketogenesis. Increased ketogenesis leads to ketoacidosis. Then ketone bodies are filtered and appears in urine. That's how ketone bodies appears in urine. Okay. Then the specific gravity, definitely you know the specific gravity of the urine, normal specific gravity. If the specific gravity is increased, why there is specific gravity is increasing? It is because you can see that the strip says, in observation of the strip, it says that there is presence of glucose, and then specific gravity is also looks a bit high. So you can say that it is due to the presence of glucose in urine, the specific gravity of urine is increased. Okay. Then in this type of patients, they say diabetic ketoacidosis, where the ketone bodies are present in urine. So what will be the pH, change in this patient? So the patient may have the pH change, means the patient maybe the blood pH will be a bit decreased. That means the patient may be acidotic. So we call it metabolic acidosis. And for metabolic acidosis, primary mechanism of compensation is the respiratory compensations. Okay. Then the abnormal constituents, sometimes you may find that some nitrite are present. Okay. So when the nitrite are present, nitrite can be present if there is any urinary tract infection, UTI. So the nitrite can be present. Then if nephrotic syndrome, if you find that the protein present in the urine. So what is the reason of protein present in the urine? Maybe the patient is having the nephrotic syndrome or acute glomerulonephritis. Okay. That's all. Any questions? Anyone? Hello?
No
Does
other
anyone
questions.
have any question?
No, doctor.
Everyone okay? Rania? Rania, Patricia,
No, doctor.
are you okay?
Okay, doctor.
Alia, Damia, okay? Mohammad Noor Iman,
Okay, doctor.
okay? Amni Wafa,
Yes.
anything? Hana Mardia, any question?
Doctor.
No question, huh? Irdani? Okay. Okay, so the no question. Then, okay, wish you all the best. Okay. So thank you very much for joining this revision. And after this, the Dr. Rehana will join. Okay. So I will just leave so that Dr. Rehana will join and she will continue. Okay. You can just wait.
Okay, doctor.
Okay. Thank you